Hey everybody, this is John coming at you with some Block 4 wrap-up. Quick shout-out. I want to give everyone a big kudos for being able to complete the last 8 weeks. It's gone by quick. I want to thank everyone for the great discussions, the great work, the hard work. I know it's not the easiest, but you guys stuck to it, and everyone finished strong. So here we go. Just quick objectives, kind of what we're going to be talking about, and we'll get going. So for everyone who completed their first management course, great job. There's also some that finished in their fourth management course. So whether you took your first course for this process or this is your last, everyone did a fantastic job, and way to go. Tremendous thank you to our TAs, Brandon and Anthony. You guys made Sydney and I's job a whole lot easier. So with all of their knowledge and information that they've been able to gain through their process, I was able to pass on their experience to you guys within the boards, and it was quite evident. So thank you to both of you guys. All right, going into this week's research. So the Nice article talked about the brain of patients with chronic pain being different from the healthy brain in both structure and function. Besides the impaired motor control of the spinal muscles, patients with CSP also exhibit hyperexcitability of the central nervous system and brain abnormalities such as decreased brain matter density. They went on to say that a treatment compromising therapeutic pain neuroscience education along with cognition targeted motor control training can be applied. In contrast, the systematic review that we also had to look at compared the effects of motor control exercises with individuals with low back pain. They were able to provide exercises aiming to activate, train, or restore the stabilization and coordination of these deep muscles. And they found that motor control exercises probably are more effective than a minimal intervention for reducing pain, but probably does not have an important effect on disability in patients with chronic low back pain. There were no clinically important differences between the motor control exercises and other forms of exercises or manual therapy for acute and the chronic low back pain. So basically, the Nice article says that motor control alone with the PNE is important for individuals with persistent low back pain, where the systematic review looked at the effectiveness of the exercises, which stated that they were probably effective, but less so for individuals with persistent low back pain. In regards to traction, there seems to be some lackluster research in this topic, and Thackeray et al. Were looking for some inclusion criteria, and this is some of the more recent evidence to come out, and they determined that there is no evidence that mechanical lumbar traction in combination with an extension-oriented treatment is superior to the extension-oriented exercises alone. So doesn't get a lot of publicity, but it is something to take into account for sure. Important to differentiate between these three terms. We want to make sure that when we are dealing with sliders and tensioners, we want to make sure to consider the symptom irritability. What stage are they in? Is it more acute versus chronic? And then with our neural testing, being able to assess straight leg raise versus slump versus femoral nerve, and making sure that when we're performing these tests that they are standardized to be able to create consistency in the reproducibility of those tests. Now, true radiculopathy only is present in approximately 5% of the individuals with low back and leg pain. We want to make sure that we're using that term correctly, because clinically that term can get used relatively common when we just said only about 5% of the individuals actually will have a true radiculopathy. So we would notice that there would be some positive neurological testing, so whether that's decreased myotone strength, altered dermatome sensation, decreased reflexes. We would want to make sure that there is a thorough neuro exam performed, especially if symptoms are distal to your gluteal fold. We also want to make sure that we're cognizant that referred pain can occur into the lumbar structures throughout the lower extremity. Chronic pain is something that definitely can and does have its own place. We could do a full 8-week course on just chronic pain in itself. So to touch on it in 1 week is just to kind of get some feelers out and to realize the importance and the effectiveness of it. But pain in itself is produced in the brain as a reaction to perception of danger to the body tissue. And the pain experience has many influences, which is basically the pain neuromatrix, where there is no one pain center. The pain becomes hypersensitive, and we provide the interventions to decrease the sensitivity through graded movement strategies and exposures. We definitely want to make sure that we're including the biopsychosocial factors, as well as educating and producing small incremental and measurable goals throughout the process. With the patient case, everybody did great in regards to the discussion. Some things to remember is how much vigor we are producing, the amount of treatment duration and or the amount of treatment performed throughout the process. Remember to consider and reconsider the SINs as we're going through this. There are multiple times where we will over or under evaluate someone, and then being able to determine and self-evaluate that process as we're going. In this patient, remember to differentiate between the lumbar versus hip, and then the manual versus exercise component in the treatment plan. The biggest way to test the effectiveness of an intervention is through the test, treat, retest component. So we test to find the associated symptoms. We perform what we believe is a intervention that will decrease the symptoms, and we retest the same finding to reassess to see if there was any change in their symptoms, making sure that we're consistent with positioning throughout the process. So if you're testing a particular test supine, make sure that when you retest, you're doing that same test in supine or sitting or whatever position that you're in. Some last minute housekeeping notes. Please download any material that you'd wish. Go ahead and build your library. Keep as many of the articles as you would like. Use as references. Keep within the clinic. Videos, however, cannot be saved. Your FIT projects we're already done, so don't worry about that. Quiz is due by midnight. And if you could please complete the course evaluation to let us know how we did. If there's any changes that would be pertinent, that would be fantastic to know. Otherwise, again, you guys did amazing. Good luck. Those of you who are continuing on, hopefully Sydney and I will be able to help you out through the process. Those are who are done, congratulations. And regardless, if you have any questions or concerns, please feel free to reach out to myself or Sydney, and we would be more than happy to help you out throughout the process or with any questions. Otherwise, great job, guys. Hopefully we'll see you later. Thanks.